Usually, when we think about fixing something that's sagging or leaking, we kind of default to the mindset of a mechanic.
Right, yeah. Like tightening a loose bolt.
Exactly. I mean, you have a leaky pipe, you tighten the valve, or, you have a sagging suspension bridge. You just crank up the tension on the cables.
It is, well, it's the most intuitive approach we have.
Mm.
If a physical structure is failing to hold things up, you add tension.
Yeah.
You pull it tighter, and the problem goes away.
But when you step into human anatomy, and specifically this surprisingly complex area that most people completely misunderstand, the pelvic floor that mechanics rent is it's the absolute worst tool you could use.
Oh, absolutely. It can cause a tremendous amount of damage.
So today on this deep dive, we are looking at a complete paradigm shift in how we treat this part of the body. We're exploring this really delicate, high-stakes medical puzzle.
Yeah, the balance between tightening a weak pelvic floor and, avoiding the really dangerous trap of making it too tight.
Right, and we're pulling from some heavy hitters for this. We've got the latest clinical guidelines from the National Institute for Health and Care Excellence, or NICE.
Along with physiotherapy protocols from the POGP network and various clinical insights on tissue disorders.
Because whether you are like a runner experiencing weird pain deep in your glutes, or maybe someone recovering from childbirth, or just intensely curious about how your biomechanics actually function, this changes everything.
It really does. We are moving completely away from that simple mechanical engineering mindset.
Because that old blanket advice of just do your Kegels is not only outdated, it might actually be harmful.
Right. And to understand why the medical community is moving away from that advice, we really have to look at how we got there in the first place.
Makes sense.
For decades, the standard historical view of the pelvic floor was almost purely mechanical. Imagine a muscular and fascial hammock sitting at the very base of your pelvis.
Okay, hammock.
Yeah, and its primary job, 24 hours a day, is supporting the pelvic organs. That means the bladder, the uterus, and the rectum.
And I guess the assumption was always that when things go wrong, it's because that hammock has simply stretched out, like it's lost its elasticity.
Exactly. The clinical term for that is vaginal laxity, and over time, that laxity can eventually lead to pelvic organ prolapse.
Which is when those organs literally start to descend or bulge down into the vaginal canal, right?
Yes, because the floor beneath them is just given out. And the main culprits for this weakening are usually structural traumas or, hormonal shifts.
Like vaginal childbirth.
Right, especially with a high birth weight baby or
Yeah.
prolonged labor, but also just the natural aging process.
And I read menopause plays a massive role here too, right?
It does. The drop in estrogen significantly reduces the collagen that keeps those hammock tissues firm and resilient.
Wow. And the daily reality of that laxity is just incredibly disruptive. I mean, we were talking about a constant, heavy, dragging feeling in the pelvis.
Yeah, that heaviness is a very common complaint.
And there's stress urinary incontinence, that dreaded leaking when you cough, sneeze, or laugh, plus even things like vaginal air noises due to the complete loss of tension in the vaginal walls.
It really affects every aspect of a person's life, from exercising to socializing.
So because those symptoms are so physical and so focused on a loss of tension, the medical industry historically responded with, well, a purely mechanical fix.
Right. The assumption was always weak and loose, so the standard treatments have been entirely focused on tightening the area back up.
And the first line defense is always pelvic floor muscle training. Everyone knows them as Kegel exercises.
Yes, Kegels are the classic prescription. Sometimes people even use devices like vaginal weights to build muscle resistance.
Literally lifting weights with your pelvic floor.
Literally lifting weights, yes.
But I was reading about the next step up from that, and it gets intensely high-tech. There's this huge market for energy-based therapies.
Oh, yeah. Devices like the NuV CO2 laser or Thermiva radiofrequency treatments.
Okay, wait. How does a laser or a radio wave fix a muscular hammock? It sounds totally like science fiction.
I know, it sounds crazy, but it's a fascinating application of physics to human tissue. The CO2 laser targets the upper layers of the tissue, while the radiofrequency waves penetrate into the deeper layers.
To promote blood flow. Right?
Yes. What they're actually doing is heating the vaginal tissue to about 40 to 42 degrees Celsius.
Which is really hot. That's intentionally causing a mild thermal injury.
Exactly. It's microtrauma. The body registers that heat and that minor damage, and it triggers a healing response.
Oh, so the body rushes in to produce new collagen and elastin.
Right, which in turn shrinks and thickens the tissue back down, restoring some of that lost tension. And when those energy therapies or the Kegels aren't enough, surgeons perform a vaginoplasty.
Where they go in, literally remove the excess tissue, and suture the muscles tighter.
Exactly.
So, to sum it up, the traditional view basically treats the pelvic floor like a stretched out trampoline. You pull the springs tighter, you use lasers to shrink the fabric back down, or you surgically cut out the slack.
That's been the prevailing logic, yes.
But wait, if that's the established medical fix, just tighten the trampoline. Why are we even doing this deep dive? Like, it sounds like modern medicine has this completely solved. Why doesn't just squeezing everything tighter fix everyone's problems?
Because the pelvic floor isn't always a stretched out trampoline. Very often, it's the exact opposite.
Really?
Yes. And this is the revelation that is changing pelvic health right now. We have to completely flip the script and look at the hypertonic pelvic floor.
Hypertonic, meaning too much tone, too tight.
Too tight, overworked, spasming, and completely exhausted.
Wow.
The narrative is shifting from this assumption that pelvic floors are always weak and floppy to the reality that they are frequently locked in a state of high tension.
And this isn't just a fringe issue, is it?
Not at all. The clinical data shows this affects 14 to 26% of women. And surprisingly to many, 12 to 16% of men suffer from chronic pelvic pain related to this exact same dysfunction.
Wait, men too. That is a massive demographic of people essentially walking around with a completely different mechanical problem than what they see advertised.
Exactly. It's a huge blind spot.
So is the feeling different? If someone has a hypertonic floor, are they feeling that same heaviness or looseness we talked about earlier?
No, the symptoms are radically different, which is why it often gets misdiagnosed. Instead of a feeling of looseness, patients experience deep internal pelvic pain.
What does that pain feel like?
Well, for women, this often mimics severe menstrual cramps. For anyone, it can present as mysterious deep glute or hip pain, particularly after high-impact activities.
Like running. I was actually looking into the biomechanics of running, and every time your foot strikes the pavement, you're carrying 2 to 3 times your body weight.
Right, it's a huge impact.
And your pelvic floor has to contract to keep your organs stable and prevent leaking with every single stride. If you do that for 5 miles, the muscle just gets locked in that contracted state. It like forgets how to let go.
It stays in a state of spasm, creating a physical hurdle. This leads to other severe symptoms like painful sexual penetration because the muscles literally will not yield.
Oh, wow.
And ironically, instead of the classic leaking when you cough, a hypertonic pelvic floor often causes difficulty starting urination.
Really? So you can't even go when you want to?
Exactly. You might sit on the toilet and feel like you have to go, but you can't initiate the stream,
Sure.
or you feel like you can't fully empty your bladder or your bowel.
Yeah.
The muscles are so tight they won't release the sphincter.
I mean, constipation has to be a massive trigger here. If you're chronically straining, you're putting immense downward pressure on an already exhausted, locked up muscle group.
Yes. It creates a vicious cycle. The pain from constipation makes you tense up, the tension creates more pain and tightness, and suddenly your pelvic floor is essentially locked in a vice.
Okay, wait, I need to clarify something. If a tight muscle is an exhausted muscle, it can actually cause the exact same leaking issues as a weak muscle.
Yes, it can.
So it's like a clenched fist that's just too tired to hold water.
That's a perfect way to look at it. If you hold your fist clenched as tight as you can for an hour, and then someone asks you to grab a heavy glass of water, your hand is going to shake and you're going to drop the glass.
Not because the muscles in my hand are inherently weak, but because they're fatigued from being constantly turned on.
Right, they have no reserve power left to do the actual job.
So if someone has this hypertonic, exhausted, clenched fist pelvic floor, and they go to the internet, type in pelvic pain or leaking, they're going to see the standard mechanics advice.
They're going to be told to do Kegels.
Which is?
The worst possible thing they could do.
Right.
If you have a tight, spasming pelvic floor, blindly doing more Kegel exercises will dangerously exacerbate the hypertonicity. You are literally commanding a spasming muscle to spasm harder.
That sounds excruciating.
It worsens the pain, it worsens the incontinence, and it can even worsen prolapse symptoms because the tension pushes the organs down further.
It's adding tension to a bridge that is already buckling from being pulled too tight.
Exactly.
But there's another massive curveball in this balancing act. What if the hammock itself is made of the wrong material?
Oh, this is where it gets really complicated.
Yeah.
This brings us to connective tissue disorders, specifically conditions like hypermobility spectrum disorder, or HSD, and Ehlers-Danlos syndrome, or EDS.
Yeah, we're hearing a lot more about hypermobility lately.
If connecting the dots between tightness and weakness wasn't complex enough for clinicians, treating a hypermobile patient is a true high-wire act.
Let's look at how that actually changes the anatomy we're talking about. So hypermobility means that the connective tissue in your body, the fascia and the ligaments, is fragile. It's overly stretchy.
Right.
And in the context of the pelvic floor, that hammock isn't just muscle. The muscles rely heavily on the fascia and the ligaments to anchor the organs to the pelvic bones.
But if you have EDS or hypermobility, your ligaments aren't doing their job. They're too loose.
Because they're built with bungee cords instead of steel cables.
Exactly. Because the ligaments are stretching too much, the pelvic organs start to drop, and the pelvic floor muscles sense this downward movement, the threat of a prolapse, and they panic.
So they step in to do a job they weren't designed for.
Yes. They overgrip. They stay in a constant, hypercontracted fight-or-flight mode just to maintain basic anatomical structure.
This makes perfect sense. I mean, telling a hypermobile patient to tighten up with more Kegels is like telling someone carrying a heavy boulder to flex their biceps harder instead of helping them put the boulder down.
That's a great analogy. You aren't solving the problem. You are just exhausting the muscle further.
But the prevailing medical myth has long been that a hypermobile patient just has a weak pelvic floor because their joints are loose, right?
Yes, that's the myth. But the reality is, these patients are almost always suffering from extreme hypertonicity. They are overclenched. They need a highly tailored physiotherapy plan focused on coordination and relaxation, not just stronger contractions.
And traditional tightening treatments are actually dangerous for these patients, aren't they?
Highly dangerous. Aggressive strengthening or stretching can overload their unstable pelvic joints, leading to painful subluxations.
Which is where the joint partially dislocates.
Yes. And surgical tightening, like the vaginoplasty we discussed earlier, carries a much higher risk for EDS patients.
Because their tissue is so fragile.
Exactly. They have notoriously poor wound healing, and there is a high likelihood of the prolapse simply recurring because the underlying tissue the surgeon is suturing together is still fundamentally faulty.
So if you're listening to this and you've got pelvic symptoms, maybe you're a runner with glute pain, or you leak when you sneeze, or you have joint hypermobility, how do you know if you need to strengthen or relax? Can you figure this out at home?
The clinical guidelines strongly advise against trying to diagnose and treat this alone at home.
Yeah, that seems risky.
The risk of doing the wrong exercise and exacerbating a hypertonic floor is just too high. You need a professional assessment. And health services are actually adapting their models to make this easier for patients to access.
Like the FAST model I was reading about. Fast assessment, start treatment.
Yes. Historically, patients with pelvic floor dysfunction would sit on agonizing 3 to 5 month waiting lists just to be seen.
Ugh, that's awful.
The FAST model gets patients in quickly for a short, highly targeted clinical evaluation, including a physical exam. They walk out of their very first appointment with an immediate, tailored treatment plan.
How do they actually test the muscle during that physical exam? I know there's a structured grading system they use to figure out exactly what the muscles are doing.
One of the gold standards in the physiotherapy protocols is the perfect scheme. It's a comprehensive physical assessment where the clinician grades different aspects of the muscle's function.
And they pair that with the modified Oxford scale, right?
Okay.
Which grades raw muscle power from a 0, meaning no contraction at all, up to a 5, which is a strong holding squeeze and lift.
Exactly.
Perfect is an acronym, right? Let's break down what they're actually looking for, because it proves this is about so much more than just squeezing.
Sure. P stands for power. That is the raw strengths on that Oxford scale. E stands for endurance. Can the patient hold that maximal squeeze for 5 seconds? 10 seconds.
Okay, got it.
R is for repetitions. How many times can they repeat that endurance hold before the muscle fatigues?
So they're basically testing the stamina of the hammock.
Right. F stands for fast contractions. Can the muscle perform quick, 1-second flicks? E is for elevation. Does the muscle actually lift the internal structures upward, or is it just squeezing in place?
Which is an important distinction.
Very important. C is for co-contraction, ensuring the patient isn't just cheating by squeezing their glutes or their abdominals. And T is for timing. Does the muscle fire at the right moment?
But the most critical part of this exam, especially concerning everything we've talked about with the hypertonic trap, isn't in the acronym at all, is it?
No, it's not. The International Continence Society guidelines insist that clinicians must check for the release.
The relaxation phase.
Yes. After the patient performs a maximal contraction, the clinician has to verify if the muscle can drop back down to a 0 resting state.
Oh, so if a patient can squeeze up to a level 5, but their muscle only relaxes down to like a level 2 or 3.
That is a massive red flag for hypertonicity. The muscle has forgotten how to turn off.
But testing someone while they're lying flat on a clinic table doesn't mimic real life. I mean, you don't leak urine when you're taking a nap. You leak when you're running for the bus or lifting a heavy box.
Or chasing a toddler, which is why there is a major shift toward functional upright assessment. Physiotherapists are increasingly assessing patients while they are standing up.
Because gravity changes the entire biomechanical landscape.
Exactly. Standing up results in a significant increase in intra-abdominal pressure bearing down on the pelvic floor.
It's like testing the suspension bridge while the cars are actually driving over it.
Perfect analogy. So a clinician might ask a patient to perform a standing cough test. They evaluate the muscle's ability to dynamically counteract the sudden, forceful downward pressure of a cough while simultaneously fighting gravity.
And that reveals deficits that simply don't show up when a patient is lying down.
Exactly.
So once a clinician figures out what the issue is, let's say they discover the patient has a hypertonic floor and needs to learn how to relax. How do they treat that? I mean, how does a patient actually learn to relax a muscle they can't even see?
This is where treatments become highly specialized. One of the most effective tools is biofeedback.
Okay, how does that work?
Imagine looking at a computer monitor. A clinician places surface electrodes around the pelvic area or uses a small internal probe. Those sensors measure the electrical activity in the muscles.
Oh, like an EKG heart rate monitor, but for your pelvic floor.
Exactly like that. The patient can watch a graph on the screen. When they squeeze, the line goes up. When they relax, the line goes down.
That takes all the guesswork out of it.
It really does. If a patient thinks they are relaxed, but the line on the screen is still hovering halfway up, they realize they are subconsciously holding tension.
So the visual feedback trains their brain to actively lower the line, effectively teaching them how to let go.
Yes. And that real-time data is incredibly validating for a patient who has been in pain for years.
I bet. What about manual therapy? Can a physical therapist actually go in and release those muscles like a massage therapist would for a tight back?
Yes, pelvic health physiotherapists are trained to perform internal and external manual therapy. They physically examine the muscle tissue to find specific trigger points.
Knots of contracted muscle fiber.
Right. By applying targeted, sustained pressure of those trigger points, they can force the muscle to release. It is fundamentally the same concept as getting a deep tissue massage for a knot in your shoulder, just applied to a much more delicate, specialized area.
Okay, so they use biofeedback to train the brain and manual therapy to release the knots. What about in the moment? Like when a patient is out in the real world carrying groceries and they feel a sneeze coming on?
Clinicians teach functional strategies, and one of the most vital is called the knack.
Which sounds incredibly colloquial for a medical intervention.
I know, it does, but clinically, the knack is a highly effective, conscious pre-contraction of the pelvic floor muscles.
A pre-contraction.
Yes. You train the patient to deliberately squeeze and lift the pelvic floor in the exact millisecond before an event that dramatically increases abdominal pressure. Right before you cough, right before you sneeze, right before you lift the grocery bag.
You brace the hammock before the boulder drops into it?
Exactly. You are consciously coordinating the muscle to absorb the shock. And over time, training the knack rewires the brain's automatic timing, so the muscle learns to brace itself dynamically without the patient having to even think about it.
Wow. If we step back and look at everything we've covered today, the sheer complexity of this area of the body is staggering.
It really is.
We started by dismantling the old mechanics myth that a malfunctioning pelvic floor just means you have a loose hammock that needs to be tightened with lasers or stitched up or fixed with 10,000 Kegels.
Right, and we uncovered the painful, often ignored reality of the hypertonic pelvic floor, where the muscles are completely exhausted from constant spasming.
Which causes deep pain, mimics weakness, and creates a vicious cycle of tension. And then we looked at the structural curveball of connective tissue disorders.
Yes, we saw how hypermobility forces muscles to overgrip to compensate for loose ligaments, making traditional tightening advice not just ineffective, but actively dangerous for those patients.
Which naturally led us to how clinical assessment is evolving. Finding the correct balance requires evaluating power and endurance through things like the perfect scheme.
But it equally demands evaluating the ability to fully relax.
Yeah.
And doing all of that functional testing in upright, real-world positions.
So I guess the major takeaway for you listening is that your pelvic floor is a dynamic, living support system. It requires coordination, perfect timing, and endurance, not just brute strength.
Absolutely. If you are experiencing symptoms, the answer isn't necessarily just squeezing harder. It is seeking a tailored professional assessment to find your specific biomechanical balance.
But if we zoom out to the entire body, this raises a really important final thought. The research briefly touches on the impact of chronic coughing, severe allergies, and even how a person breathes during heavy weightlifting.
Right, because all of those factors dictate the downward pressure on your pelvic organs.
Because your diaphragm, the muscle you use to breathe, and your pelvic floor move together. When you inhale, your diaphragm pushes down and your pelvic floor lowers to accept the pressure.
And when you exhale, they both come back up. They work together like a piston.
So since that respiratory pressure dictates how hard your pelvic floor has to work every single minute of the day, it completely reframes how we view pelvic health.
It really does. Could optimizing your respiratory health, managing chronic coughs, and simply learning how to breathe properly actually be the ultimate secret weapon for long-term pelvic floor longevity?
That is a brilliant thought to leave on. Maybe before we worry about the tension on the cables of our suspension bridge, we should look at the wind and the traffic pushing down on it first. Thanks for joining us on this deep dive. We'll catch you next time.